I'd like our first speaker to come up and join us, Dr. Agarwal. Yep.
Okay. Dr. Bittner, Dr. Hayward, thank you so much for the opportunity to talk to you about defining and measuring quality in surgical education. Just my disclosure. So I'm going to kick straight in with a study which I think is the best study which really looks at quality of medical education. And the holy grail of educating our residents is really to enable them to deliver great care when they go out into practice. And this is a study done by David Ash, Andy Epstein, and other colleagues at the Wharton School in Pennsylvania. And basically, as you see, it's looking at a specific area of patient outcomes in obstetric care and using patient outcomes to evaluate the quality of obstetric residency programs. And what they basically did is, the context is that patient outcomes have been used to assess performance of hospitals, of physicians, but residency programs haven't really, and this was published in 2009, so there's some data since then, but hadn't really up to that point been compared, and most comparisons have been on non-clinical measures. So their objective was to assess whether OBGYN residency programs can be evaluated by the quality of care their alumni, so the graduating residents, deliver. So what they did is they looked, it was looking at all the obstetric discharges for Florida and New York hospitals over a 15-year period, which represented about 5 million deliveries performed by over 4,000 obstetricians in 100 residency programs. And their main outcome measures were maternal complications, and they put this together as a composite measure of all the complications put together, including vaginal and cesarean deliveries. When you look at their outcomes, what they did is, looking at all the residency programs, the over 100 residency programs, they looked at the number of deliveries for cesarean, for vaginal, and then they looked at the outcomes of those hospitals. So, and then they put the residency programs in 5 quintiles. So the best quintile hospitals had a 10.9% complication rate, and the lowest quintile had a 14% complication rate. So first of all, they found differences, and this has been shown at the hospital level many times. And then what they did is they looked at the people that have been trained in those programs, and then they looked at their outcomes actually in practice. So there were a total of, as I said, over 4,000 practicing physicians who are out in practice, who've been trained in each of these quintile residency programs. And then when they looked at the outcomes in practice, they found that if you were trained in a high quintile residency program, then your outcomes were actually in the highest quintile as well. And if you're trained in a lowest quintile residency program, your outcomes in practice were within, more likely to be within the lowest quintile. And so their comment is that patients, trainees, educators, people who hire physicians probably share the view that where a physician is trained gives at least some indication of how good that physician is currently. But what they actually found was, what they found is that where an obstetrician completed residency may provide a meaningful and consistent signal about the risk of maternal complications among that obstetrician's patients when they're in practice. And they found also that these rankings were stable across individual types of complications. They measured 9 in total. And also, interestingly, I didn't show the data for this, but they weren't associated with residents' licensing examination scores. So this wasn't a selection effect, that the best residency programs are just selecting the best people, and then they're going out into practice and being the best physicians, okay? So that didn't factor into this. So this is really, to me, the best data that's out there, the only data actually that's out there that's correlating residency programs to patient outcomes. And when we want to move on from this, we think, well, okay, we all know about the US News report, best medical schools. You can see what they are here in terms of research, primary care, a number of other aspects. And, you can rate anything using the US News report. And really, what I'm trying to say is, David Ash did this study, so should we have a rating of best surgical residency programs like this? So the closest we've got to that, and this is the data that I could find, and Frank Lewis presented some of this, was a standard across general surgery residency programs. So it's pass rates for the board examinations, for the qualifying exam, for the certifying exam, and for both together. So there are 3 columns here. The first column is the pass rate for the qualifying exam, the second is for the certifying exam, and the third one is the first time pass rate for qualifying and certifying exam, which is obviously what we want for all of our residents. And I've taken the names out, but you can see here for a couple of programs, okay? So the first program, the qualifying exam success rate is 95%. Certifying is a little bit lower at 84%. And their overall first-time pass rate is 78%. You look at another program, the qualifying exam success rate, only 3/4 of residents are getting through that, whereas all of the residents are getting through the certifying exam, but again, the combined rate of first-time passers is similar. And then you compare that to another program where they're passing everything. It's 100% off the board. So there is definite variability using ABS examination pass rates, whether that's the right metric or not, but certainly using that, which is an absolute necessity to go out into practice, there is already variability across the board here. So what we want to do is say, well, where does this variability come from? And as with any kind of health services research, how can we enhance that variability? It's not about kind of saying, we're only going to train in the top 20% of residency programs. It's about how can we bring everyone up to a really great level to create more consistency, because that's what we want to do. And there was a recent editorial, it's just pre-print at the moment, written by people that you know, John Mellinger, John Morris, Richard Damewood, and they said, assessing the quality of graduate surgical training programs, a perception versus reality. And basically their 3 take-home points were, what we want to do in terms of graduate surgical training is graduate great surgeons, but the training program reputation is an imperfect and potentially dangerous metric to rank training programs. So what they're really referring to is the Doximity reports, US News World Report. And really in association with what David Ash's work said is that we need to measure patient-orientated program quality. And what that really means is we need to be looking at the patient outcomes of our graduates. In the UK, the Joint Committee on Surgical Training, which is kind of the group which gives you your independent license under the Royal College of Surgeons, they've developed quality indicators. So they've come together with the surgical training committees, develop a series of quality indicators. And what they say is to enable the quality of training placements within each surgical specialty and at the core level, at the junior level, to be assessed. These are not to assess the achievements of individual trainees. We already do that in a number of different ways, but they will be used to identify good and poor quality training placements in order that appropriate action may be taken. And the way that they wanted to measure this was through a trainee survey, okay? So there's an example of the quality indicators. The generic, they're for different specialties, general surgery, plastic surgery, cardiothoracic surgery, and so forth. And for example, trainees should be allocated to approved posts commensurate with their level of training. Trainees should have at least 2 hours of facilitated formal teaching each week. And then there are specifics for the higher levels for the ST. This is a mid to senior resident. Trainees in general surgery at the ST5-6 level should have the opportunity to undertake a wide range of operations as defined by the curriculum for the ST5-6 to achieve the ST6 competencies. And when they had all these quality indicators, and then they sent this survey out across the country to all of the trainees, and basically they said, so, does your post that you're in meet this indicator? And so these are the responses across the board for 2011-12 and then 2012-13 for all of the different specialties. And you can see, for a start, they've defined it by specialty rather than they could have defined it by region. They could have done it in different ways. But there's variability across the different specialties. And none of the specialties is really at 100% for meeting the quality indicator to be able to attend weekly operating room sessions. The quality indicator for attending weekly clinics, again, there's great variability here. There are some places where it's almost 100% and others where it's, some specialties I should say, where it's 40 or 50%. And then responses meeting the quality indicator for weekly formal teaching. So you can see here across the board it's actually pretty poor. And so this is something that the JCST can take and say, well, across the board we really need to improve weekly formal teaching of our residencies. So that's the background, that's what JCST is doing. I'm going to tell you about a little bit of work that we've been doing, as one of my PhDs has been working on back in the UK. And the objective of this was to define high-quality surgical training and then do some kind of quality improvement initiative. And so we wanted to define it, as you can see there, define the methods to measure quality, because we didn't really feel that the quality indicators were that robust. They're pretty loose, and then use that to measure training quality and then hopefully to improve the quality of surgical training. So we did a four-phase approach. The first phase was the development phase. This was semi-structured interviews to really identify from trainees, from trainers, what is high-quality surgical education. And we did the interviews, we recorded them, transcribed them, and then we coded them to identify emergent themes. Taking that forward, then we took those themes and we wanted to do this not just for a local region, we wanted to do this at an international level. So actually we launched this at the ICOSET, or the International Conference on Surgical Education and Training meeting, which was held in Ottawa, I think in 2012. And we took the themes from the interview study, we identified what were the indicators, we identified international experts in surgical education, and we asked them to rank each statement as to its importance in terms of measurement of quality of surgical education on a scale of 1 to 5. And then, as with many Delphis, we took the consensus as 80% to the experts ranking this, and then we fed this back at a second round to ensure that we hadn't missed anything out. Phase 3 was then to take that information and to develop what we called an SQAT, a surgical training quality assessment tool. Really took each of these measures that we'd found from the semi-structured interviews and then from the Delphi, and then put them, as you know, in a rating scale from 1 to 5, where there was low quality for certain metrics and high quality for certain metrics. Some of those metrics may be relationship between the trainee and the trainer, personalization of training, exposure to appropriate cases, and so forth. And the fourth phase, which we're doing at the moment, is to develop a regional quality improvement model for surgical training. So we're doing this in the Northwest London training region. Training in the UK is quite different to training in the US. It's not based on academic centres, it's actually based on regions. And within the region of Northwest London, a population of about 2.5 million, there are 13 centres for general surgical training. Some of them are community hospitals, some of them are affiliated university hospitals, and some of them are full university hospitals and academic health science centres. Of these 13 centres, there are a total of 96 faculty trainers in general surgery, a median of 8 with a range of 1 to 12 per centre. So we identified the trainers, we focused on the trainers to start with, by electronic mail, and sent them this questionnaire to rate the quality of their own training program. Obviously there's bias there, which is obvious, but we really wanted to start somewhere. And so when they rated it, we had 12 out of the 13 centres responded. Only 36 out of the 90-odd faculty trainers responded, so only 1/3. So that's again another source of bias, with an experience of 10 years as being an educator. What's interesting, whilst this is qualitative, is the areas of highest quality as rated by the trainers were the trainer approachability and attitude towards trainees performing operative cases, trainee rapport with other trainees, and the balance between supervision and independence in outpatient clinics. These were rated the highest across the board for the 36 trainers. Areas of greatest variation, the greatest standard deviation we found, were provision of designated training operating lists, structure of the technical and non-technical skills teaching programs, so whether that's simulation or whether that's other aspects, and learning objectives for endoscopic skills as well. And the areas that we found of lowest reported quality included the teaching programs. That was already seen actually in the JCST report. But the presence of designated operating lists and trainee evaluation, the trainers themselves said that trainee evaluation was pretty low. So for example, in terms of the teaching programs, one of the attending said, we have extensive academic training on offer, but it's very much focused at the research fellows rather than the clinical trainees being able to do some further academic work. In terms of designated operating list, this was a comment from a hepatobiliary center. Most of the procedures are complex. So it doesn't make sense to send junior trainees, but that's what was happening. And then training evaluation. There's very little feedback from training committees. This is the trainers saying they are not getting feedback on the quality of their training from the training committees. It's very much the feedback being given to the trainee. And it's just informal feedback from some trainees. So the trainers themselves said, we really want to know how we're doing and how we can improve. So putting all that together, this is a quote that I used in a talk a couple of days ago, but I think it's quite apt for a number of reasons. Edwards Deming talks about, we've learned to live in a world of mistakes and defective products as if they're necessary to life. It's time to adopt a new philosophy in America. I think we already are, and part of that is having this panel. There's a number of things that are going on, and we're really on the crux of a big change in surgical education in this country. So thank you once again for the opportunity to talk about some of this work.